to another webinar organized by Forum for the Study of the Liver. As you all know, we have been organizing these type of webinars throughout the COVID pandemic, but today's one is very special because today with us we have a legendary hepatologist from USA, Professor Robert J. Gish, who will be updating us on the latest managements of hepatocellular carcinoma, which is a challenge for us across disciplines for hepatologists, for internists, for oncologists and surgeons alike. Today we have an elegant panel of experts with us. I have the pleasure of introducing Dr. Mohammad Fazal Karim, who's an associate professor and head Department of Hepatology at Salimullah Medical College in Dhaka. With us is Dr. Kutubuddin Mullik, associate professor and head Department of Hepatology, Khulna Medical College, and Dr. Abdullah Al Mahmood, who's working as an assistant professor in the Department of Hepatology in Chitta Medical College. Before we are expecting some more panelists to join, but without wasting any further time, it is now my pleasure to invite Professor Robert Gish to update us on management of hepatocellular carcinoma. Professor Robert Gish, please.
Thank you very much, Professor Shwapnil, and the rest of the panel. Your wonderful, very friendly, warm, gracious introduction. I'm here to talk about a part of liver cancer management. There's so much to cover these days with all the different modalities that we have for managing HCC. And what's really interesting is that the last 3 days, there's been what's called the International Liver Cancer Conference, ILCA, that was supposed to have been in Madrid, but ended up being a virtual conference. But I've been sitting watching these virtual lectures for a couple of days now, and it's just a huge amount of information, very exciting. And I've managed to weave information from ILCA into this presentation today to try to make this as current as possible. I do work as a hepatologist and I do manage liver cancer patients. I sit on a number of tumor boards in the region. I live in California. I have a practice that covers Northern and Southern California and also Nevada. So I either travel or see patients in person in a variety of settings throughout this region and work with a number of different universities. I'm on the faculty at Loma, but I also work with other organizations because we want to give our patients the best care. So let's focus on ablation of liver cancer and systemic therapies. I won't be talking very much about resection or transplant, so let's keep all that in mind. See if I can get this to go forward. I have a website that has lots and lots of resources, including disclosures, seminars. There's a newsletter you can sign up for at my website, and I push out a lot of information. There's a lot of PowerPoint. This PowerPoint will be posted on my website as well. So this is an introductory slide. Most of the people in the audience already know this information about how important liver cancer is in terms of a leading cause of cancer, a leading cause of cancer death. Liver cancer is the primary form of PLC, HCC, the primary form of primary liver cancer. Hepatitis B and C are dominant, but NASH is, of course, accelerating. You all live in the Asia region, and Asia is dominant in terms of where those liver cancers are found. And there's a
sir, let me interrupt. I'm sorry to interrupt you, but would you please share your slides, sir? We don't see the slides, sir.
Oh, what happened to share? Hang on a second. Looks like the share stopped. Had it all set up. Let's try it again. All right, are you seeing the share now?
Slides, so thank you very much.
Okay, some reason it stopped, but I'm going to do a little bit of a switch here and get the right screen presentation. I want to fill out the whole screen. Is that correct? Okay, looking good. Thank you. Sorry about that. Sometimes we go in and go back out. Anyway, we're going to be talking about a number of these standard of care treatments along the right side. Okay, what is ablation? Ablation is a percutaneous process that can be done through the skin or laparoscopically, open, microwave, RFA, cryo, alcohol injection. Another form of ablation, local-regional therapy, LRT, is embolization. This can be bland embolization, chemoembolization, DEB, those are bead embolizations that can take place. Then we have radiation. You can have external radiation, which can be SBRT, Proton also is getting a lot more attention these days, although the equipment is phenomenally expensive. And then, of course, transarterial radioembolization. We'll be talking a little bit about that today as well. This is an update on the management from the usual BCLC criteria. You need to know the stage of your patient, performance score, their child's Pew score. Very, very important. You need to know, of course, the MELD score of your patient. You need to know the number of nodules. You need to know if there's portal invasion. You need to know if there's lymph node or distant metastases. This is all critical. You need to estimate portal pressure. If you can't estimate it, you should measure it. And that can be done through transjugular. There's now an endoscopic technique to measure portal pressure from a Cook device that can be done through an endoscopic ultrasound. You need to assess bilirubin. Direct bilirubin is much better than total bilirubin for liver function assessment. It's a very good liver function test. You have to look for associated diseases, of course, both directly that affect the liver or systemic diseases. You then move through resection, transplant, ablation, embolic, and of course, this can move multiple directions. You can have stage migration to the right or stage transition to the left, depending on progression or regression of the disease. But overall survival continues to improve. And targeted therapy, if you look at targeted therapy in sequence, you can get overall survival that can be out to 30 months. This is very, very exciting. A little bit more on this. Transarterial embolization, you've got different types of microspheres that are present. The conventional TACE is just oil with doxorubicin, but may contain cisplatin or mitomycin. There's an ischemic effect followed by a chemotherapeutic effect. These drug-eluting beads have less ischemic effect, but more of a chemotherapeutic delivery. Radioembolization are either resin or glass microspheres. The glass microspheres appear to be more popular these days, more data, more dose delivery. You can fine-tune your dose a little bit better. There is a microembolic effect, but mostly it's internal radiation. TACE is the recommended local regional therapies. Now, this is very much dependent on tumor size. So if you have a tumor up to 3, microwave is dominant, maybe RFA. 3 to 7, TACE is dominant. But in this world, it's not just one test. TACE plus thermal ablation is the state of the art in the tumor centers where I work for up to 7. Once you're above 7, you're moving to radioembolization, especially if you've got branch chain portal vein embolization, clot or tumor. So local regional therapy, this is BCLC B, and as you know, B can be subdivided into different categories. TACE is recommended. We talk about a size limit here, up to 7, typically if you have combination therapy. Microwave is preferred because it's got better control, thermal control, near blood vessels such as the portal vein, hepatic artery, or bile ducts. Look at the median survival. It can go out to 40 months. And there are a subset of patients with local regional therapy that actually have the primary tumor cured. That's probably in the 15% range, but that is a possibility. Although I usually don't discuss cure with patients until you prove they've been cured, because of course they're at risk for recurrence in other locations if the diseased liver is still in place. The CTP score is best less than B8, just like for systemic therapy. We'll talk about that in a few moments, meaning compensated disease. If the bilirubin's normal, but they have ascites, I'm less worried. If the bilirubin's normal and they have hepatic encephalopathy, I'm more worried because encephalopathy means a lot of shunts. You may not be delivering drug or therapy to the liver directly. TACE failures, you need to identify early. This could be by biomarkers or by imaging. Because if you keep trying to TACE patients, you may result in liver dysfunction that's rather marked, and then systemic therapies are no longer an option. Most of our systemic therapies, including ICI and TKI inhibitors, really we aren't going to use those above Child's B8, and even limited for B7 and B8, Child's B7 and B8. There is data for sorafenib and nivolumab in more advanced Child's B patients, but this is limited data, and you do, of course, need to be cautious. Post-treatment imaging is very important. I want to emphasize here that all of your imaging in these patients should have LIRADS, this liver imaging reporting and data systems, should have a LIRADS score treated, and LIRADS scores M for metastatic disease, LIRADS score, and measure your tumor, and then use the M-resist, which means the diameter of the residual disease, where you see arterial enhancement and venous washout. This is much better than RESIST 1.1. There's lots of data on using M-resist to talk about response, non-response to therapy. And again, I really want you to be following biomarkers. Alpha-fetoprotein, very important. And I use a triple biomarker panel, AFP, L3, and DCP. I use this triple panel to talk about response or non-response. Here we talk about partial response, progressive disease, and stable disease by definition in terms of percentage. Really important to have appropriate institutional quality on your contrast CT and your contrast MR. Now, there's a lot of controversy about whether you should be combining targeted therapy with TACE. This could be TABE or TACE, this embolic therapy. A lot of interesting studies. There's a series of retrospective studies that hinted that this was a benefit to be using this. And there's some theory behind what sorafenib does. It's a VEGF inhibitor. It blocks a number of intracellular signaling pathways that may enhance TACE, or TACE may enhance sorafenib effect. Unfortunately, in randomized controlled trials, except for the TACTIC study that came out of Taiwan, there was no difference. And it may have to do with timing. It may have to do with the type of systemic therapy used. And we still need to learn. We still need to design these studies carefully. If you treat patients for long periods of time after TACE in the sorafenib TACTIC study from Taiwan, longer treatment did show a survival benefit when used in combination with TACE. So I'll say there is one paper or combo therapy, but it had specific limits or specific delineation of where that benefit would take place. All right, TACE or TARE, what are those dividing lines? So TARE is more important for multifocal bilobar disease, where you may be wanting to do a segmentectomy or a radiation lobectomy. TACE, little role if you have portal vein invasion. Now, branch portal vein or segment portal vein invasion, really your best choice is going to be TARE, transarterial radioembolization. If you have main portal vein invasion, you need to be thinking about systemic therapy or possibly SBRT. But TARE does not do well in main portal vein invasion. In advanced age, where patients may not tolerate systemic therapy, TARE is effective. And as you recall from the SARA or Cervinib studies, that TARE was equivalent to sorafenib, but had a better quality of life. So radioembolization, if available, should be considered. We talked about liver function, ascites, encephalopathy, direct bilirubin, extremely important, not just total bilirubin, as well as looking at albumin, INR, MELD score, total TPT score, CPT score. You need to look for portal hypertension. Is flow reversed in the portal vein? You need to look for shunts to the lung, all important. And performance status. Do these individuals have sarcopenia? Do they have a high frailty index? Please put that into your calculation. Now, this is TACE versus TARE. This is a meta-analysis of 3 randomized clinical controlled trials, 3 prospective studies. And it really is variable in terms of how you're going to look at these outcomes. The size of the tumor, the number of the tumors matter, but it looks like in these larger tumors, TARE is your best advantage. In smaller tumors, TACE is probably your best option. TARE had less frequent adverse events, especially abdominal pain in these individual patients. We're looking at very interesting overall survival that can stretch out to 5 years. Barcelona staging is very important. This highlights a lot of the different treatment options that are available. This does not have all the information because one of the things I'll talk about at the end of this presentation is atezolizumab and bevacizumab. This is really telling us that we have many choices. I understand in Bangladesh, lenvatinib is a leading choice, and I'm going to talk about that in great detail. Dr. Shwapnil gave me that lead to help focus on that, because that's what you're using. And we're going to talk about what is that data. So systemic therapy right now, first line, we list atezolizumab, a PD-L1 inhibitor, plus bevacizumab, a VEGF inhibitor. We also have sorafenib, lenvatinib, which are multi-kinase inhibitors. Look at the wide variety of second line therapies that we have here. We will only have one medicine, ramucirumab, that is biomarker directed. What I want to say here is we have an absence of markers such as PD-1 or PD-L1 staining. We don't have data that MET might help us determine patient outcome or which medication we choose. Hopefully with the checkpoint inhibitors, the CTLA-1 inhibitors, CTLA-4 inhibitors, we're going to have options by staining or by blood tests in the near term. Also, cabozantinib has very interesting effects on the immune system. It may actually be an immune activating medication that could enhance the effects of our checkpoint inhibitors. But this choice is just dramatically changed all in the last 24 months. Let's talk about sorafenib and lenvatinib just for a few moments. This is sorafenib efficacy. Most of you have seen this. Phase 3 international multi-center trial. Primary endpoint, overall survival. Secondary endpoint, time to progression. Progression-free survival is another interesting endpoint that may become a surrogate for overall survival. I encourage you to look at the ILCA website, join ILCA, and look at all the lectures that occurred over the last 3 days. This time to progression or progression-free survival may end up being the primary endpoint in the development of new phase 3 studies, because the number of patients to prove overall survival difference may be in the 1,000 to 2,000 patient range, because we have so many patients making it much longer time periods, over a year, over 18 months in terms of median survival now. Lenvatinib, the data came from the REFLEX study. This is an oral multi-kinase inhibitor that targets VEGF 1 through 3, FGFR 1 through 4, platelet-derived growth factor, as well as RET and KIT. And on the right side, you see these in vitro kinase inhibitory profiles. What I want to highlight here is that eventually we're going to be biopsying patients. We're going to be highlighting what receptor mutations they have, what signaling pathways they have, what genomic changes they have. Do they have TERT mutations? Do they have Wnt beta-catenin mutations? And then we'll choose a drug based on that. We're not quite there yet, but it's time that we really get oriented to these different kinases where these mutations are. In the REFLEX study, we had regions, Asia Pacific versus Western. We had main portal vein invasion in terms of stratification, but ECOG stratification and body weight. This, of course, was body weight dependent in terms of dosing at 8 versus 12 milligrams. Sorafenib was the control arm here, primary endpoint overall survival. It's very important that we use M-RECIST for outcomes, not standard RECIST, because standard RECIST doesn't really measure tumor effect. You want to see when you have partial tumor necrosis, partial tumor kill, to say whether you're having an effect or not on that HCC. Now, the REFLEX study, this is a non-inferiority study, lenvatinib at 13.6, but importantly here, look at the change we've got now with sorafenib with a median survival of 12.3. It's very important that they designed this study as a non-inferiority study. I thought this was an excellent idea. It was well powered and they had that proof, but some of the important points that come out of this are along the right-hand side. Look at the response rate, lenvatinib in this box at 41% versus sorafenib at 12%. We have complete response, minor, partial response at 38%. Now, why do we see this better response rate but not a change in overall survival? Well, some of it has to do with the study design, patient selection, what patients went on to get other treatments. So in the lenvatinib, in the REFLEX study, a large number of the patients in the sorafenib arm went on to get other medications, including 20% that went on to get immune checkpoint inhibitors. But here, up front, you're seeing what I think is a superiority. The other issue is that we aren't treating the underlying liver disease as aggressively as we should. Hepatitis B, all patients should be on nukes and suppressed. Hepatitis C. As soon as you see a hepatitis C patient, they should be treated until cured. There's all sorts of confusion in the guidance among different KOLs about whether to treat hepatitis C. I'm going to make a statement here. Treat all hepatitis C immediately. Ignore these rumors of what I call fake news that hepatitis C might make the liver cancer worse. Even if that's the case in 2 to 3% of patients, the benefit of treating the hepatitis C, where there are 7 major benefits, far outweighs any risk. Okay, so now you're getting a good story about lenvatinib having some potential superiority to sorafenib. Now, subplot analyses sometimes are helpful, but now you're really chopping the patient population into much smaller units. But it looks across a variety of different areas, including AFP, etiology, BCLC staging, whether it be B or C, and you're seeing equivalence across these different patient populations. So this is very important. So it's not the patient population that lenvatinib is going to miss. Now, this is a secondary endpoint we were talking about. Progression-free survival, which we think a number of recent publications, including one by Yovet last year, or PFS probably is a better surrogate for what's going to be seen in terms of overall survival long-term. So lenvatinib, almost twice the number in terms of PFS, 7.4 versus 3.7. So in this way, lenvatinib is superior to sorafenib. Tumor assessment took place, so objective ORR, objective response rate that was seen here. We have mRECIST by investigator, mRECIST by independent review. That ORR even looked better. Version 1.1 by independent review. As I mentioned, I'm not going to be using 1.1. I'm going to be looking at these 2 central columns of mRECIST. So this is either consistent or better by independent review. Tumor assessments by sorafenib, also a slight difference here by independent review compared to investigator. Okay, now if you have a response, that really changes your overall survival. So if you have a response versus a non-response, and this is where you need to make a determination between 2 and 4 months of your therapy. If you're having a non-response, that's time to change to a different therapy. So make that decision early, again, while you're treating the underlying liver disease. But if you have this objective response, overall survival is substantially better. Now, adverse events are very, very important. I think there is a difference between lenvatinib and sorafenib. As you can see here, hypertension was a little bit worse, but diarrhea was better, appetite and decreased weight about the same, fatigue maybe a little bit worse, but the PPE, palmar-plantar erythrodysesthesia, was substantially less. So that's very, very important to be thinking about. Elevated liver enzymes can be seen, but ends up being about 1 out of 7 patients here. Rash in general was less. Alopecia, much less. So I think in some ways, lenvatinib is a little bit better tolerated than sorafenib, as well as this improvement in progression-free survival. Now, real life. Let's go to a real world here. This is a paper that was just published recently, a retrospective observational study that was here. And there's an important part of this study is that this included Child's Pew B patients. But there was a higher rate of hyperbilirubinemia in the Child's Pew B, including any grade or grade 3-4. So how do I dose these oral TK inhibitors? So if I'm using sorafenib, I'm going to start all my patients out at 400 and move up to 800 if tolerated. Same thing with lenvatinib. I'm going to start at a lower dose and dose escalate, provided that liver function is not changing. Very importantly, in the Child's B patients, very important because there may be some accumulation of the drug and it may actually change liver function. I can't say that it's directly hepatotoxic, but we know cirrhotic patients, especially Child's B, have decreased drug metabolism. Well, now we have proven clinical efficacy of a number of approved agents for advanced HCC. On the second line here, the overall response rate or objective response rate for lenvatinib is the best from the reflex study at 24%. We're also showing better median progression-free survival and time to progression. So these are very interesting numbers to be thinking about, but it's exciting that we have so many interesting options. Ramucirumab for high AFP, cabozantinib, which may also be immune active and work well with immune checkpoint inhibitors. Now, what about combining lenvatinib with other medications? We have phase 2 data that has logic on the left and data on the right when we're combining lenvatinib with pembrolizumab, a PD-1 inhibitor. Here we have a median overall progression-free survival on top of 9.3 months and overall survival. Now we're up in the 22 month. Now again, this is phase 2 data, needs to be confirmed in phase 3, which is an ongoing study right now. But the future of treating HCC, just like we're going to see when we show data on the atezolizumab, bevacizumab, is combination therapy. The lack of combination therapy is probably why a number of medicines that we could have used, such as brivinib, never made it to market. Now, combination here, this is just going back to what we talked about with the TACTICS trial, which is a phase 2 study in the far right. This was a combination of a Taiwan-Japanese collaboration up through B7. Pretty large tumors. This is up to 10 centimeters, up to 10 tumors. See TACE on demand, but look at the progression-free survival. Substantially better than the other studies, SPACE, TACE2, and post-TACE, which had much, much lower endpoint with TTPs or PFS or less than 10 months. We're at 25 months. In the TACTICS study, they clearly showed that the patients who benefited the most were the patients who were maintained on sorafenib the longest. And maintaining people on sorafenib, just like any of the TK inhibitors, is dependent on dosing and how you manage the side effects. Some providers give up easy. There's a skin reaction, give up. There's fatigue, stop the treatment. I'm strongly advocating dose de-escalation and dose escalation. In a large post-marketing study, such as Gideon plus another study, it was shown with sorafenib that starting at 400 milligrams and dose escalating as tolerated had the same overall survival and the same progression-free survival as starting at high dose. And that's probably because the patients starting at low dose could tolerate it better. They had tachyphylaxis to side effects. Side effects could be managed more easily. All right, let's go to our wrap up here. Atezolizumab and bevacizumab in the US. This is our first line therapy. The IM Brave 150 trial design is here. They had Asia versus rest of the world, performance scores up to 1. They had macrovascular invasion and extrahepatic spread. They did have a binary breakpoint of AFPs of 400. Now, it's important to note that atezolizumab and bevacizumab are intravenous therapies every 3 weeks. So the patient has to be willing to travel, get intravenous therapy, and in our corona times, oral therapies are more favored because patients can pick up a prescription and take those medications at home until loss of clinical benefit or unacceptable toxicity. This is a first-line study, and then they did a survival follow-up. Efficacy results, they still have not reached their median overall survival. We're thinking it might be between 20 and 30 months. That's going to be a profound shift. But as you can see here, sorafenib looks pretty good at 13 months. Hazard ratio, now this is calculated at 6 months, had a hazard ratio of 0.58, so 40% improvement using the AB combination over sorafenib. We also had better progression-free survival, and that hazard ratio was almost the same number at 0.59. This was statistically significant. Secondary endpoints, such as objective response rate, was much better, moving from 11 to 27, using RECIST 1.1. But look below where we should be looking, which is mRECIST. We're moving from 13 to 33. Safety results, of course, when you're going to be choosing this AB combination, you have to be thinking about bleeding from bevacizumab, make sure varices are well controlled, peptic disease is well controlled. You have to monitor for proteinuria. You have to monitor for a variety of different autoimmune events from the PD-L1 inhibitor, atezolizumab. The good news is This does not appear to cause reactivation of hepatitis B or C. So the IM Brave showed an improvement of these two medications over sorafenib. And what I want to highlight here, even though these drugs may be expensive in Bangladesh, may not be available because of their costs, the future really is going to be combination therapy. I'm looking for the data for levantinib and pembrolizumab to come out, final data from phase 3 that's ongoing. So we have first-line choices here. What we're going to be focusing on, of course, in this discussion is levantinib because that's available in Bangladesh. Very interesting results, potentially less side effects, oral therapy that's very favorable in these corona times. So how do we make decisions when choosing our various treatments? Let's walk through this as we plan to wrap up our session. Are the patients pending a liver transplant? What's their bleeding risk? It's not just the INR, but I believe that thromboelastography is the state of the art for checking bleeding. And I hope at your liver centers that you're using TAG now to look for bleeding status, bleeding risk. Immune checkpoint inhibitors, you have to be thinking about autoimmune diseases. If there's an underlying autoimmune disease, this is a problem with these patients. What's their performance status? Can you move them from a ECOG 2 or 3 down to a 1 or 2 with physical therapy, with nutrition? Look at all organ functions, including liver function. Treat hepatitis B to suppression. Treat hepatitis C for cure. Treat NASH for best therapy. Control diabetes, control the fatty liver. Manage disease-related symptoms aggressively to improve quality of life. You look at tumor burden. Make sure you're using LIRADs. Make sure you have appropriate metastatic testing, including chest CT or bone scan. What's the aggressiveness of that tumor? And alpha-fetoprotein, AFPL3, and DCP really help you determine whether that's going to be an aggressive tumor or not. Look at the GALAD score. Look at the absolute level of these 3 different biomarkers. Hepatitis B and C versus non-viral may be different, especially if you're treating the B, curing the C. We have breakpoints for AFP, for ramucirumab, of course. There are other breakpoints. AFP greater than 10 or 100 are breakpoints for chance of recurrence after liver transplantation. Does the patient have already a lot of diarrhea? Well, TK inhibitors are going to be a problem. They've got bad psoriasis. TK inhibitors may also be contraindicated. Control hypertension, although that's pretty rare in cirrhotic patients. Do they have proteinuria from hepatitis C? Do they have cryoglobulinemia, nephrotic syndrome? Treat and control that underlying disease. VEGF inhibitors can cause hypertension and bleeding risks as well as proteinuria that I mentioned before. What's the regulatory approval? What's your reimbursement? What's patient preference, especially in the corona times? They may not want to be traveling or coming into a medical center for intravenous therapy. AFP level we talked about, GALAD score we talked about, but we don't have biomarkers yet for a number of these other, especially oral TK inhibitors. There are emerging markers where we think checkpoint inhibitors, microsatellite instability, total tumor burden, TMB, total mutational burden, immune signatures, PD-1 or PD-L1 expression. Keep your eyes open for those as well. So we want to treat liver cancer to a cure, but we can't cure all patients. We need to have better surveillance, earlier detection, earlier diagnosis, better biomarkers. Once we move to ablation, we have a number of different options. I think microwave is better than RFA, shorter time, better tumor control. TACE and TABE are very useful. I think up to 7 is my rule, provided that you're combining TACE, TABE with microwave. So really it's back to combination even early. We'll be learning soon about doing this combination therapy, including Y90, TACE, TABE, and adding immune checkpoint inhibitors, or even dual therapy, such as VEGF inhibitors. And then we have a variety of other studies we need to take place, provided we have the proper study design. It's exciting that we have excellent drugs like levantinib, what I'm going to call the AB combination, and we have 2nd, 3rd, and 4th line options. This is very important to be thinking about. Cabozantinib has really good data as a 3rd line option, but of course all of these could be potential 3rd or 4th line drugs. So finally, tell your patients to stop drinking alcohol, moderate their metabolic syndrome as part of best management. A little bit about the future here. With that and pembro, we talked about other ICI therapy, immune checkpoint inhibitors, proton beam, SBRT, CERT. There's all sorts of immune changes that take place when you do radioembolization. There's a lot of interesting studies about radioembolization followed by NEVO. That's called the NASR HCC study. There's a new form of ablation called irreversible electroporation. This might even be an improvement on microwave ablation. Biomarkers, genomics, immunomics, such as measuring CD8 T cells. Soon, I think we'll be biopsying unresectable HCC patients, so we have a basic profile. What's the immune profile? What's the genomic mutation profile? What are receptor mutations, such as fibroblast growth factor 3 mutations? Very important for choosing future therapies. And thank you very much for having me. I hope you're having a wonderful meeting.
So thank you very much indeed. Thank you for enlightening us. It was a very helpful lecture and with lots of updates. There's one small question for you, which is by Dr. Pankaj Naha from Dhaka. He wants to know, what would you recommend as the investigation of choice to see recurrence of HCC after curative treatment? Say, for example, after a curative surgery, how would you recommend following up the patient for recurrence of HCC?
So that's a great question. So we're going to follow patients with imaging and biomarkers. I think everybody agrees right now that the 3-month interval is probably the best. There's a very important paper that I just saw yesterday at the ILCA meeting about what the margins are around different tumors, and it has to do with AFP levels. So the higher the AFP level, the larger your margin. So let's say a surgeon comes back to me and say, well, I couldn't get a 1 centimeter margin because of vascular or other anatomical reasons. I might be checking biomarkers, such as the GALAD score triple panel, as early as a month. But definitely at 2 months, I'd be doing imaging. 3 months would be standard. And then it depends on your local imaging expertise. CT is cheaper than MR, but MR, I believe, is more sensitive and specific. And if I have a mystery case, I might even go as far as doing a PET CT. But MR every 3 months, gadolinium, using LIRADs, multiphasic would be my recommendation.
And so one more thing, after a curative surgery, do you recommend sorafenib or lenvatinib for such patients, or wait and follow?
Great question. So we don't have good data. We have the SPARE study, which is the post-resection, showing that sorafenib did not help after resection. That was a negative study. I would use post-resection oral multi-kinase inhibitors in high-risk patients. High risk is macrovascular invasion, moderate risk, microvascular invasion, low risk, no vascular invasion. And I'd also be looking at biomarkers. Now, of course, AFP can hang around for up to 6 months. But if you check monthly biomarkers after a resection, all those biomarkers should be coming down stepwise every 4 weeks. The biomarkers are flat or going up. I would be instituting some type of oral targeted therapy early after resection.
And sir, one more question. For patients with portal venous thrombosis, is it absolutely contraindicated to do TACE, or we can do TACE if the local expertise is there for selective cannulation and if there is blood flow within the portal vein still maintained?
It's a great question. So you have to talk to your radiologist. Is the portal vein thrombosis malignant or bland? And the data for malignant portal vein invasion, whether it's segment or branch, especially for main portal vein invasion, the TACE has less efficacy. So I'm going to prefer Y90, but if you don't have Y90 available, you could consider TACE, and you probably have SBRT available. So I would think about TACE plus SBRT. It goes back to this whole concept of combination. If TACE doesn't look to do well with portal vein invasion, it's not time to give up TACE, but time to think about TACE as combination therapy.
So, and let me see, So there's another question, sir. How do we decide if we want to repeat TACE in a patient? How do we assess that the patient has not responded or has had a past episode of TACE and we want to do it again? How do we assess the patient decide?
Great question. So it goes back to the 8 to 12 week rule for imaging. For TACE, I'm going to look at an 8-week response. I'm going to assess 50% or greater reduction in arterial enhancement. Less than 50%, I'm going to call that a TACE non-response or partial response. I'm going to consider one more TACE in that patient. But if I can't achieve that next 2-month interval, at least a 50% reduction in arterial enhancement, I'm going to say TACE is not working. That's also a bad prognostic sign. But instead of beating on the patient, trying to ruin the liver function, and then not be able to give some type of systemic therapy, we're not doing the patient a service. So moving quickly from a TACE failure to systemic therapy, such as lenvatinib, is the current standard of care.
Okay, sir, and thank you very much. I now go on to the panel of experts. We have more panelists joining us after we started. So I'll start with Dr. Fazal Karim, as a professor and head department of hepatology at Dhaka at Sir Salimullah Medical College. Dr. Fazal Karim, if you please give your expert opinion, please unmute yourself and give us your expert opinion.
So thank you very much for a great lectures. I am very much learned very much from you, sir. So I have some queries from your lecture. These are, you have stressed about a direct bilirubin in assessing response. Is it very much helpful, or why not total bilirubin? And second question is, can we use sorafenib before doing a test? Is there any problem with using sorafenib before doing test?
Okay, so question one is total bilirubin is a messy liver function test because many patients have hemolysis. Could be from hypersplenism, red cell abnormalities, something else occurring, or Gilbert's. So when you have a total bilirubin, you have indirect, which is a hemolytic portion, but the direct is your liver function test. That's telling you about what that liver's doing. A healthy direct bilirubin is 0.4 or less milligrams per deciliter. You'd have to convert that to micromoles, but I'm assuming the number's in a similar range. If you have more than a doubling of your upper limits of normal of your direct bilirubin, there's very significant liver dysfunction, and you need to adjust dosing or your treatment plan. Direct bilirubin is the best liver function test. Sorafenib before TACE, we don't have really good data on that. There was the SPACE study that was done also, STORM for resection, SPACE for TACE, and that was also a negative study. But as I mentioned, the TACTIC study was good, but that depended on continuing sorafenib for a long period, up to 30 months after TACE. Thank you.
One more thing is, can we use lenvatinib in decompensated liver function?
So it's a great question. I looked at 2 different manuscripts on that yesterday as part of ILCA. It's clear that once you're in the B8 to B9 group, there's a much higher increased risk of lenvatinib causing cholestatic changes, a higher total and direct bilirubin. So if I was to use it in a child's B8 or B9, I would start at 1/2 or 1/3 the dose and dose escalate carefully in those patients. So it's not contraindicated, but be cautious.
Thank you very much.
Thank you, Dr. Fazal Karim. Now I go on to Dr. Muhammad Izazul Haq, said professor and head Department of Hepatology at Kumilla Medical College, for his comments. Dr. Izaz, please.
Thanks, Professor Dr. Robert Gish, for this excellent update presentation on hepatocellular carcinoma. We know the management of the hepatocellular carcinoma is based on BCLC staging system. In the early stage, we have options of hepatic resection, transplantation. In the intermediate stage, we have ablative therapy, TACE, and in advanced stage, that is systemic therapy. In our country, we have first line 2 drugs, sorafenib and lenvatinib. The second line drug, regorafenib, which is not available in our country. So the surgery is the mainstay of treatment of hepatocellular carcinoma. Professor Robert Gish has given data about the combination therapy. The drug that has been used with the sorafenib and lenvatinib, it is not available in our country. One question to Professor Gish, what is your experience about sorafenib or lenvatinib? Which one is better?
So I have treated over 80 patients with sorafenib. It's my greatest experience. I've only treated about 10 with lenvatinib. My message about sorafenib is that a third of patients have severe adverse events and just have to stop treatment. Another third progress on sorafenib early and should be changed to a second-line therapy. I think you probably have regorafenib in Bangladesh, I'm assuming that. But you could also consider lenvatinib as a second-line therapy if you start with sorafenib. But a third of patients respond well to sorafenib, and side effects can be managed in those individuals, especially with dose reduction and dose escalation. From a small case series in my practice and what I've seen in the literature, I believe that lenvatinib has some superiority to sorafenib with less side effects and better tumor control. And lenvatinib would be a first-line option in my practice. Combination, lenvatinib or sorafenib, TACE, or surgery would have to be done on a case-by-case basis.
Thank you very much. I think so. I have also got many of the patients with serious adverse effect with sorafenib, mainly hand-foot syndrome. So we have to stop the drug. I think lenvatinib is superior to sorafenib. It's a personal experience only. So thank you very much for this updated lecture. And thanks to moderator, Professor Mamun al-Mahtab.
Thank you, Dr. Haq. Now I go on to Dr. M.A. Rahim, Associate Professor and Head Department of Hepatology at Abdul Malik Hukin Medical College in Noakhali. Dr. Rahim, your comments, please.
Please unmute yourself.
Good evening. First of all, I thank Professor Dr. Robert Gish for his elaborate and very fruitful lecture, and we earn a lot from this lecture. This webinar is arranged by Forum for the Study of the Liver, Bangladesh, and also Hepatology Alumni Association, Bangabandhu Sheikh Mujib Medical University. I thank also Forum and Alumni Association, and also it is sponsored by Beacon Pharmaceuticals. Thanks Beacon Pharmaceuticals, and also the moderator, Professor Mamun al-Mahtab, Shwapnil, for moderating this webinar. Thank you to you all.
Thank you very much, Dr. Rahim. Now I go on to Dr. Harun al-Rashid. He's an Associate Professor at the Department of Hepatology at Rajshahi Medical College. Dr. Harun al-Rashid, if I can please have your opinion. Dr. Harun, if you please unmute yourself, please.
Can you hear me?
Now we can hear you, yeah.
Okay. Thanks, Dr. Professor Robert G. Gish, for your good, excellent lecture. Many more learned from your lecture, especially from the research papers. I have small questions about the sorafenib and lenvatinib. Your lecture shows the lenvatinib is more effective than sorafenib, but both are kinase inhibitor. Lenvatinib is more effective because it has less side effects. This is the only cause, or many more other cause for effectiveness of lenvatinib. Please say.
Well, you have to look too that the targets of lenvatinib are different than the targets for sorafenib. And just like regorafenib is a sister drug of sorafenib with a different molecule, it's affecting c-KIT, MYC, other genes at different levels. And as you know, there's a huge amount of tumor heterogeneity, intratumor and between different tumors in the same patient, where the patient may have 3 or 4 tumors. So by having multiple classes of drugs, multiple points of inhibition, you may be benefiting some patients more than others. It may also decrease side effects because your dosing may be less because you have a drug that's hitting more receptors, more changes in the tumor. So I do think lenvatinib has a better progression-free survival. I think it has less side effects. I think the overall survival advantage may have been picked up if it was a larger study, better powered. And of course, if you treat the underlying liver disease aggressively, you may end up seeing a survival advantage with lenvatinib.
Thank you.
Thank you,
Dr. Professor Mamun Mahtab and all my colleagues. Thank you.
Thank you very much, Dr. Harun Rashid. Now I go on to Dr. Kutubuddin Mullik, Associate Professor and Head Department of Hepatology at Khulna Medical College. Dr. Mullik, if you please give us your valuable opinion.
Thank you, sir. Thank you, Professor Robert Gish, for deliberately and elaborately giving us a nice lecture. Thank you, Professor Mahtab, Shwapnil, sir, for selecting me the panelist. Actually, by this way, we can continue our academic activities at this pandemic situation. HCC is actually a leading cause of cancer death, all right, especially our country, as hepatitis B virus is a common in our country. I am especially living at the peripheral part of our country where HCC cannot manage invasively. The lenvatinib is the novel anti-cancer drug we know by this webinar for HCC management, as we can prescribe after confirming our diagnosis if the patient are not taking invasive therapy. By this webinar, especially speaker, Professor Gish, who already give us the management of HCC. Hope all the participants acknowledge about the update management of HCC, also LENMA. Thank speaker, scientific partner, Beacon Pharma, also the participant. Thank you all.
Thank you, Dr. Mullik. The last panel expert member is Dr. Abdullah Mahmood, who happens to be a good friend. He's an assistant professor of hepatology at Chitta Medical College. So, Dr. Mahmood, if you can have your opinion, please. Yes, Mahmood, we can hear you.
Thank you, Professor Robert. This was a very nice meeting, and it was an excellent deliberation by Professor Robert. Thank you very much. Enlightened. Carcinoma, the most important topic for an hepatologist, oncologist, and surgeons also. It is the fourth leading cause of death, liver cancer, and in Bangladesh, hepatitis B is the leading cause of hepatocellular carcinoma. And as a third world country, we do have only the first line drug, the sorafenib, and the latest one, the lenvatinib, and we are practicing. And from today's lecture, we came to know that lenvatinib is at least not inferior to sorafenib, and it is better regarding the side effect profiles. And the only LOCO-REGIONAL therapy, TACE, is available in our country, as well as the radiofrequency ablation. And from this panel, I will congratulate Professor Mamun Mahtab because he is the pioneer of starting TACE therapy in our country. And he has got a lot of experience, and a lot of patients are taking treatment. And finally, I thank Forum for the Study of the Liver and BSMMU Hepatology Association and Beacon Pharma for arranging such a nice webinar. Thank you very much.
So, with this, we come to the end of this session. As we have learned that this was yet another scientific endeavor by Forum for the Study of the Liver Bangladesh, jointly with BSMMU Hepatology Alumni Association. The scientific partner was Beacon Pharmaceuticals. We are extremely grateful to Professor Robert Gish. We know how busy you are. It was our pleasure and honor for us to have you here. And we look forward to hosting you physically in Bangladesh, hopefully next year. We are extremely grateful to the panel of experts for giving us their valuable opinion, and of course the participants who have made it successful. This webinar was live on an IPTV in Bangladesh, ReHealth TV, which has allowed us to reach to thousands of more participants. This type of endeavor will continue from our end. This month we have two more webinars. One is on 26th of this month at 6:30 p.m. Bangladesh Standard Time. That will be the second webinar of South Asian Association for the Study of the Liver on hepatitis C virus. And on 30th, we are having a joint webinar from the Forum for the Study of the Liver with Global Hospital Hyderabad, where we'll be updated on hepatorenal syndrome. So we hope to see you there. We'll notify you as much as possible for those two events. Till then, very good evening. Thank you very much.
Assalamu alaikum.